I will talk in this lecture about the surface anatomy of the heart and its main valves. Also, I would talk about the auscultation of the heart and where we best hear the sounds of the closure of the valves of the heart. And then I would show you how to read plain chest X-ray focusing on the cardiovascular system, and then we would conclude by talking about the CT scan imaging of the superior mediastinum. Now, as you can see in this diagram here, the heart, we can outline the heart on the surface of the body using 4 points. You just need to know these points and then to draw lines between them. Some textbook they just put the point A before or B before. So in this drawing I found it one of my favorite. Point A is the upper border of the third right costal cartilage, 1 centimeters from the sternum, sternal border or the lateral border of the sternum. And point B, it is the lower border of the second left costal cartilage, also 1 centimeter from the sternal margin. So in different textbooks you may find them referring to this point as A and this point as B. It doesn't matter as far as we can draw a line between them that would give us an idea where is the superior border of the heart. So 2 points, easy. The first one is the upper border of the second costal cartilage on the right side, of course, and the second point is the lower border of the third of the second costal cartilage. So here we are talking about the third. This is the first, second, third, and here we are talking about the lower border of the second, the upper border of the third on the right side, the lower border of the second on the left side. Then we go here and count, of course. This is costal cartilage number 1, 2, 3, 4, 5, 6, and point C is the sixth right costal cartilage, also 1 centimeter from the sternum. Now we drawing a line that connects A with C, and this border bulges to the right a bit. Then we identify the fourth and last point, which is the apex of the heart. You know where to look for the apex of the heart, and fifth left intercostal space, just medial to the mid clavicular line. Of course, this point represents the apex of the heart. Now, also we will draw a line that bulges to the left, and we connect C and D. This is the inferior border, this is the left border, this is the superior border, and this is the right border. So why do we need to know the outlines of the heart, just in case if the heart is enlarged? Now, before we proceed to the next slide, which is the surface anatomy of the heart valves, let me remind you that the mitral valve and the aortic valve, they are close to each other, and the reason behind that is the way blood flows inside the left ventricle and deflected by the anterior cusp of the aortic valve in 180 degrees. So that's why they are close to each other. On the other hand, you would see the atrioventricular or the tricuspid valve far away from the pulmonary valve. Why is that? Because the blood flow the blood flows here in a Y-shaped in the direction, and that's why they are far away from each other. Now you would think that let's first of all see their surface anatomy. Here is the tricuspid valve, lies behind the right half of the sternum, opposite the fourth intercostal space. Then we have the mitral valve, the left half of the sternum, opposite the fourth costal cartilage. So the surface anatomy of them, if you look at them here, one on the left side, one on the right side, the fourth intercostal, the fourth costal cartilage, the pulmonary valve lies behind the medial end of the third left costal cartilage, and the aortic valve. I don't want you to memorize the surface anatomy of the heart valves. I just need you to orient yourself where is their location in your body relative to your ribs and the sternum. And now what matters for all of us is where to hear the sounds of these valves. And to your surprise, they won't be the same areas as the surface anatomy, and this is very important to be appreciated. The location, the anatomical position of the valves does not necessarily coincide with the place where we hear and listen to their sounds, and that is due to the hemodynamics inside the heart. And I'm sure in the physiology course they explained this very well to you. So where to place your stethoscope if you want to listen to the tricuspid valve? Best heard over the right half of the lower end of the body of the sternum. Here you need to practice this to find the right half of the lower end of the body of the sternum. There we of course listen to the tricuspid valve. Now the mitral valve, this is an easy one, the apex of the heart, where to place your stethoscope on the apex of the heart, and we repeated that many times. So the mitral valve is easy to memorize. The tricuspid valve is not that confusing when we talk about its surface anatomy. It was around the fourth intercostal space here, right half, the same opposite the fourth intercostal space. So it's not that confusing. Now when we go to the aortic and pulmonary valves, you need to ignore totally their surface anatomy. Here the pulmonary valve lies behind the medial end of the third left costal cartilage. Lies behind the medial end of the left third costal cartilage. So if we apply this, here. Now let's go and see where would we listen to to this the pulmonary over the medial end of the second left intercostal space. So of course it's far away from the anatomical surface. The aortic valve is best here over the medial end of the second right intercostal. So you just need to understand that in the second intercostal space, to the right is the aortic valve, to the left is the pulmonary valve, the mitral on the apex, and the tricuspid in the lower half of the body of the sternum. These are the main points that you are not allowed to carry on to the next step without solid knowledge where to place your stethoscope. So let's ignore the surface anatomy totally of the valves and stick to an easy places where we should put or place our stethoscopes. In the second intercostal space, the medial end of the second left intercostal space, this is the pulmonary trunk, and in the medial end of the second right intercostal space, this is the aortic valve, and of course on the apex of the heart, the mitral, and the lower half of the body of the sternum is the, of course, tricuspid valve. This is what matter. So read this, but it's not an exam material, as it does not stick for a long time in your memory, and it has just to confuse you later on. What you really need to take with you, and I will ask you about it in the exam, is the auscultation of the heart, and for easy to memorize points. Now let's here also on this diagram you can see where to place this. On a plain chest x-ray you would certainly see and easily you can identify the right and left borders of the heart. Let's talk about the left borders of the heart. Here as indicated, first of all, the left border is made out of the superior vena cava. It's rather a straight border, and then the angle between these two contours represents the superior aspect of the right atrium. Here is the right atrium, and we did mention that we said that of course the right border of the heart is made completely by the right atrium, as the right ventricle during the rotation of the heart became almost anteriorly. So therefore this the whole right atrium is bulging to the right side. Inferiorly here we would see the short segment of the inferior vena cava. So the main things that you can and you should follow on the right side of the heart, of course, a straight superior border of the superior vena cava, followed by the, of course, the contours of the right atrium, and finally with the, of course, the place where the inferior vena cava joins the right atrium. So easy things to be learned here. Mostly it is the right atrium. Above it is the superior vena cava. Below it is the inferior vena cava. Now on the left side you certainly familiar with the fact that we many times highlighted during the theoretical part of this course, or during our practical sessions. We did mention the arch of the aorta. Here it is obvious, and it is the most superior part of the left border of the heart, followed by this shadow here, which is the shadow of the pulmonary trunk and its left pulmonary branch, and then here you would see the left auricle, followed by, of course, the more larger left ventricle, making the most of the left border until we reach the apex of the heart. So this is the left border, arch of the aorta, main pulmonary trunk, and the left main pulmonary artery, and then it could be the left auricle, and followed by the left, of course, ventricle. So obviously we don't have the left atrium. As I told you, after the rotation of the heart, the left atrium became posteriorly. In fact, we did mention that the atrium is nothing but the posterior side of the heart. So this is something we already talked about. So the only thing that you may think it's here is the left atrium. It's not. If there is any part of it, it would be part of the left of the auricle, the left auricle itself. Apart from that, it is the left ventricle. On the right side, as I mentioned, it is the right atrium. Here we have right ventricle, here we have right atrium, and of course the lower border is made by the or the inferior border made by the right ventricle, as after rotation it becomes anterior, except this part we did mention that this is from the left ventricle. So the borders has been explained to you. They are easy to be picked on the plain X-ray. Now, one of the most important shadows here is the arch of the aorta, and due to its resemblance to the knuckles, we call it aortic knuckle. So if you are looking at a plain chest X-ray, you have to, and you are targeting the vascular system, identify the aortic knuckle, as it is very important not to study the arch itself of the aorta, but to find the next point here, which is the aortic window. So once you've seen and found the arch of the aorta, the aortic knuckle, now you need to look under this arch. As I told you, and many times we did discuss the relations of the arch of the aorta, and of course I was right to focus on these relations, as they matter not only as mass weight in development of tumors in such a very narrow space, which is the superior mediastinum, but also to understand CT scans. Now, what is under the arch of the aorta? The bifurcation of the pulmonary trunk comes in front, then of course posteriorly we would see the bifurcation of the trachea. Now that's why mainly we would talk now about the pulmonary trunk and its left main branch. Okay, so easy to find the arch of the aorta here, as you can see, under the arch of the aorta. We call the arch of the aorta aortic knuckle. Now under the aortic knuckle you would see the aortopulmonary window or the aortic window. What for? There you would see the of course the pulmonary pulmonary trunk and its left branch. Why we are concerned about them? Not only for the sake of the pulmonary arteries themselves, but also to highlight the fact that many mediastinal lymph nodes can be enlarged and found in this area. So this is a potential space in the mediastinum where abnormal enlargement of lymph nodes can be seen on a chest X-ray. So for example, a patient comes to you complaining about mediastinal compression syndrome, or you thinking about the aneurysm of the or you thinking about the patient coming with hoarseness of his voice, and you may think about a tumor pressurizing the structures within the superior mediastinum. You can easily ask for a plain X-ray. You will identify the arch of the aorta, then you would certainly identify the aortic window, and you would find of course the pulmonary trunk, and you may see some enlarged lymph nodes in this area. Okay, so this is the way it is. Now again here the aortic knuckle, and if you carry on you may see or follow the contour of the descending thoracic aorta. This is the lateral view of the thoracic cavity. You can identify the posterior mediastinum, superior, anterior, and middle mediastinum. Also, one of the most important measurements to appreciate the normal size of the heart, something we call the cardiothoracic ratio, aids in the detection of enlargement of the heart, which is most commonly from cardiomegaly, but can be due to other processes such as pericardial effusion. The idea here is very simple. We take between the two points that represents the largest diameter of the heart, then we take the measurements between the 2 points of the thoracic cavity from inside, where the maximal diameter of the thoracic cavity, and if the ratio between them is less than 0.5, this may indicate enlargement of the heart. The cardiothoracic ratio is something to give you an impression about what's going on. If you think that there is really cardiac enlargement, most likely you would certainly ask for echo, because it's more sensitive, gives you the diameters, gives you everything, more than of course a plain X-ray. So I'm not sure we use it to diagnose cardiomegaly, but we rather, if you been asked about plain X-ray, the size of the heart can be measured in this way to gives a reflection if it is normal or enlarged. Now also things that can be seen in patients with tetralogy of Fallot, is something we call it a boot-shaped heart, which describes the case of tetralogy of Fallot, of course. The appearance of upturned apex of the heart, look here, it should have not been here, it should be down, due to, of course, due to right ventricular hypertrophy and concave pulmonary arterial segment. All this is something you need to memorize. Tetralogy of Fallot can be seen on an X-ray like boot-shaped heart. I just can't resist to tell you the moment I memorized this X-ray, one of my great teachers told me in Arabic, Kundara-like heart. You wouldn't forget this. I think it sounds in Arabic more obvious. Now, let's move to CT scan. CT scan is just a reflection to your solid anatomical knowledge. The only thing here, just I need to make sure that you understand is that we look and study at the CT scan not from superior. We look as if we are sitting near the patient's feet here. So you are looking at this patient from down up, not from superior to inferior. A simple glance at this picture here, you would be confused. This is the liver, and this is the spleen. By size, at least, you can identify. So this would be on the right side for you, and this would be on the left side. Unless you consider what I told you, you need to look as if you are in the abdomen now, looking at the liver from inferior. Now do it. You would see the liver on the right side and the spleen on the left side. Once we've agreed up on that, we can now study the CT scans. Why these CT scans of the superior mediastinum are very important? In fact, they are very important because they are this area is an area famous for tumors, especially in youngsters and in elderly with carcinomas coming from the lung and bronchial trees. Okay, now this is very important, and of course, what else you need to know? The CT scan of the lungs, and this is I would leave for the respiratory. So the focus is on the superior mediastinum. Now, cross section through the thoracic of thorax at the vertebra T5. I would assume that now you know T5. It means that we are not in the superior mediastinum. We are in the inferior mediastinum. Hence, the intervertebral disc between 4 and 5 is the imaginary plane that divides superior mediastinum, inferior mediastinum, and therefore I would assume that T5 it is in the inferior mediastinum. And as you can see from anterior, sternum is your guide, vertebral column is your posterior guide. You can see the anterior mediastinum, the middle mediastinum, and of course the posterior mediastinum. Now, here we have something anterior. It is the, of course, ascending aorta. Next to it, it is the pulmonary trunk dividing into right and left pulmonary arteries. Don't you ever forget, this is the right side and this is the left side. Behind them, as we many times mentioned, of course, the bronchi, main and right and left main bronchi. Remember, the trachea ends at the level of the intervertebral disc between 4 and 5. Now we are at the level of 5th in thoracic vertebra. It means we wouldn't see the trachea itself, but we would rather see the main bronchi. Also, we would see at this level the descending aorta. It is always next to the vertebral column. The ascending aorta not far away from the sternum. This is something to orient yourself. Here the thymus, but we are not interested in the thymus at this time. Posterior mediastinum here, easily you can see, of course, the esophagus, and on the left side you can see here the descending aorta. Now, how this would appear on a CT scan? This is the same story here. We have this is T6 maybe, T5, T6. We would see the pulmonary trunk as it divides into right and left main pulmonary arteries. This is of course the ascending aorta, and this is the descending aorta. How I know this? This part is next to the vertebral column, and this part is away from the vertebral column. Most likely it is close to the sternum. Now, don't you ever forget that this CT scan with dye. So that's why the vascular structures seen very well. What is this here? Here, let's go here. Superior vena cava. If you remember, we talked about the ascending aorta and its relations. We said the ascending aorta, to its left the pulmonary trunk, to its right, posteriorly and right, it is the superior vena cava. So use your anatomical knowledge. You would see, of course, the superior vena cava. Let's jump into this one here. Again, descending aorta, and this is ascending aorta. Another thing you may have noticed, the ascending aorta is large, and it ascends up and becoming the arch. As it descends, becoming descending thoracic aorta, the size is smaller. So it's not only the relation to the vertebral column, of course, which is the most important thing, it's also the size here is smaller than the size there. If this is the pulmonary trunk, which is on the left side of the ascending aorta, okay, then this is the superior vena cava, which is on the right. And here you can easily see the right pulmonary artery behind the ascending aorta. We did mention that. We did talk about that many times. We still in the inferior mediastinum. We still in the middle part of the inferior mediastinum. You would see the two main bronchi, and then descending aorta, and of course the esophagus. Now let's go up. As we go up, you would see a change here as we are losing these obvious branches of the pulmonary trunk. And one more thing, here the superior vena cava is more obvious. What does this mean? What's going on? I can see the ascending, I can still see the of course descending aorta. As we go up, we're going towards the superior mediastinum. We would say goodbye to two structures, the pulmonary trunk and of course to the ascending and descending aorta, and we would see instead the arch of the aorta, and we will not see the pulmonary or its branches. We will see now the arch of the aorta as we going towards the superior mediastinum. Here you go, totally different image. This is the arch of the aorta. Remember that just minutes ago we had here ascending, descending, here two circles, and the pulmonary trunk. Now the pulmonary bifurcation and the pulmonary trunk has can't be seen. Again, your solid anatomy knowledge should tell you that once again what was under the arch of the aorta, the bifurcation of the pulmonary trunk, and of course its left main branch. Now if you see the arch, you wouldn't see them because the cut here at the same at the level of the arch of the aorta. We are in the superior mediastinum. Here still, as I told you and as I showed you, the arch of the aorta and the superior mediastinum, we have to the right side we have the superior vena cava. Remember that I told you in the lower, behind the manubrium, in the lower part we have the arch of the aorta, and in the upper half we have the its branches. Also we have in the lower part of the manubrium the superior vena cava itself, the upper part of it, and as we go above and behind the manubrium we would see the brachiocephalic which form this vein. Now this is the arch, this is inferior vena cava. What is this? Welcome to the trachea. We also said bye to the bronchi. Why? Because they can be seen only in the inferior mediastinum. Now we are in the superior mediastinum, and instead of the left and right main bronchi we would see the trachea itself, always open structure, and behind it here you would see the esophagus, which is a closed muscular structure. Going further up, it is a clear continuous arch, as you can see it here. This is the inferior superior vena cava, and this is the trachea, behind it the esophagus. Now let's go to T3 in the superior mediastinum. You would see the end of the arch now as we're going up, still the trachea, the esophagus. You may begin to see the branches of the arch of the aorta, and you certainly would begin to notice the appearance of the brachiocephalic veins. Let's have a look. Now the continuous image, which is this one, has gone as we go superior. Instead I can see three of course points or circles. This is the brachiocephalic, followed by the subclavian, followed by the left common carotid and left subclavian artery. What is this here? It is the of course the superior vena cava. Maybe it is overlapped here. We need another section to identify the veins as well. This is the trachea here. Again, here it's more obvious than this one here. This one is obvious without a doubt. This is the brachiocephalic trunk. This is the left common carotid, and this is the left subclavian artery. And here we have this one is the, we used to see the superior vena cava. Now as we go up we would see what makes the superior vena cava, which is the oblique and long left one. I can easily tell not only by the side but also by the image represented here. And this is the right brachiocephalic veins. So superior vena cava is not seen anymore. It's rather their tributaries. The arch of the aorta is not seen. We have rather here its branches, trachea and etc. Now, this is again the same CT. Okay, we were right. Here, I think we discussed this one. We discussed also this one. Here also, obviously, the three branches of the arch of the aorta, and here you have the left one. Here you have the right brachiocephalic veins as well in this image. Now, if you go at the level of T2, certainly you would begin to lose even the branches of the the brachiocephalic veins, especially the right one, but it's evident here. And now we are at the neck. I can see the shoulders here, and just the trachea, and this is not something you need to, it's not our subject to, of course, see this on the neck, but just to remind you of the of course the thyroid gland. Here we can see, and more on the thyroid gland, you will easily find it in your anatomy about the thyroid gland that I taught you last semester. Again, for your orientation, these are repetition for the slides that I talked about. Again, you can see from T2, T3, T4, and etc. Now, here we don't do it from superior to inferior. You can do it the way, you can read the CT scan the way you like, but you need to appreciate that we always looking from inferior to superior, and it would be hard for you to easily get engaged into understanding, to comprehend, I mean, the CT scan. But who of you knows the anatomy, he will not struggle, and he will enjoy reading the CT scan. Finally, let's talk about the pulmonary embolism, which is common from the veins of the lower limbs, especially with old people who travel for a long distance. History here is very important. They're coming to your clinic complaining about old man or woman complaining about their legs and pain in their legs and other complaints, but they're telling you they were traveling for a long distance from Jordan to California for a long distance, for example, and this journey may provide good conditions for the development of embolisms, thrombus in the venous system, that eventually may block the pulmonary trunk or its branches, and we can, of course, intervene if we can listen to the patients and offer for them assistance and help before the development of pulmonary embolism. And of course, don't you ever forget people who travel for a long distance. It goes without saying that these are old people who are under this risk conditions. Now again, once you became now an expert, this is an excellent, of course, CT scan. This is the pulmonary trunk. This is the ascending aorta. This is the descending aorta, and this is superior vena cava. And you can easily see the pulmonary embolism blocking the branches of the pulmonary trunk. So I have to leave it here. The CT scan, you should guide yourself. First of all, the level of the taken section, and sure you need also to make sure that you know that the descending aorta is near to the vertebral column. If you see two circles, one of them near to the descending aorta, near to the vertebral column, this is the descending aorta. The other one near to the sternum or on to the anterior side, it would be the ascending aorta. Once you identify the ascending aorta, you know that to the right of it, the superior vena cava. Make sure you understand that when you see two circles here in the CT scan, the thing that you can see with them, especially if you see the ascending aorta, you would see the pulmonary trunk. So one of these structures would indicate the other structure. If you see, if these two circles are gone, you are looking at, of course, the arch of the aorta. If the arch has gone and three circles appeared, then we are talking about, of course, the branches of the arch of the aorta. There always be guide for you, and there would be a guide for you on all CT scans. This is the vertebral column, the sternum and the thoracic here, and of course the trachea, the esophagus, and you can see all this in relation to the vascular structures.